Morning all, and thanks Simar for the kind introduction. So I would this case this is a case of vascularly active treatment naive stage 4A ROP, and I would like to share what we learned from this. And this was managed almost 10 years ago, so 10 or 8 to 10 years. So this was a 30-weeker baby, 950 gram, was screened late, around 38 week, had a storming or postnatal course, oxygen for 1 month, had sepsis, anemia, thrombocytopenia, poor weight gain, and all conducive for a severe ROP. So poor mydriasis, vitreous haze, a right eye had a vascularly active stage 4A ROP. In June 1 posterior, we can see that the nasal part, there is a broad ridge and the adjacent detachment, and and with the margin little bit inverted towards the disc. So these are the cases, they quickly close over the disc. This is the left eye. Left eye was a bit better, but the ridge was sitting on a detachment on either side here, circumferential detachment. It was in the zone 1. So laser was planned and laser done, but baby was sick, unstable, with unstable vital. We couldn't complete. So baby has to get admitted in the nearby NICU. So we planned that we probably, and meanwhile the detachment was progressing. So we thought baby would need surgery. So we kept everything ready so that we do injections, laser and surgery together. So this is this is the surgery for both the eyes. A 25 gauge lens sparing vitrectomy was done. The placement of the placement and the configuration of the ports depends on the configuration of the detachment, the extent of dissection that are needed. So these different techniques are available. I do 25 gauge, and this was that valveless cannulas that time. So I tend to put the suture at the end of the surgery to avoid hypotony and bleeding. Now the greatest concern for me are the three. One is bleeding during the surgery. The second is very adequate titrated dissection of the vitreous to relieve the major tractional vectors. As you can see in the right eye, after the injections, 2 days later, 2-3 days later, there is fibrosis and there is contraction over the disc. So if you leave them, then they can lead to crunch effect like the one shown below. So that is why we took the surgery again early, and dissection is being done. The anteroposterior traction is relieved, then the disc to the lateral wall, and very meticulous dissection, just adequate enough to relieve those vectors, because in case a bleeding happens, the blood itself at times can be worse than the membrane, and this can cause failure of your treatment. So laser was most of the laser was done before, and the doing laser has the advantage that, number one, you save time during surgery, especially if both the surgeries are done on the same day. The second, if lens is to be preserved, like here, lens sparing vitrectomy, then you may try to do it pre-op. So this is the last visit 3 months post surgery. We can see that the eyes are doing well with myopic refraction and post surgery. So at 5 years of age, we can see that is doing well. So 3 things I would like to give here: the early screening in these cases, especially the 2, 3, 4 strategy. Day 20 probably would have avoided surgery. And when we have vascularly active progressive stage 4A surgery, my preferred choice is injection, laser, surgery, all as a package, and how early we rush them to the surgery with careful dissection to avoid vitreous hemorrhage decides the surgical outcome. Thank you so much for the kind listening.
Thank you so much, sir, for that very interesting case. I would like to invite Dr. Diksha Katoch. Ma'am is a associate professor at the Advanced Eye Center and deals primarily with pediatric retinal disorders, especially ROP. Thank you, ma'am, for being here. And ma'am will be presenting a case of stage 4B ROP. If you
Thank
can
you,
have
SIMAR.
the slides quickly, one after the other, because we'll be short of time.
Thank you, SIMAR, for the kind introduction, and thank you, Dr. Tapas, for for a very nice case and telling us about what are the basic steps that are involved. So quickly, I'll just give 2 or 3 scenarios of stage 4B. Retinal detachment. So this was an outborn 30-weeker, 1780 grams, history of oxygen supplementation, diagnosed as aggressive ROP outside, and laser was done. Now here, when we see the clinical photograph, we see there is a posterior location of the 4B. There is a fold which is along the arcades, and if we look carefully, that there is also a connection, interarcadal connection, and we also see an avulsed vessel here. And the macula somewhere is dragged superiorly. So this is a 4B with a posterior location. These cases are relatively easier to tackle, and the surgery may be simpler rather than a more peripheral one, which I'll just discuss. So this is just the surgical video for this case. I try to do most with the 27 gauge transconjunctival the vitrectomy in most of my cases, and the surgical principles remain the same. Like you can see here that there is the vitreous traction going from the ridge to the periphery, from the ridge coming up anterior to the lens, it is between the arcades, that is the ridge to the ridge, also over the disc. Now, in these situations, we may use a little amount of transfer to identify the posterior vitreous tracts, but if we just try to get these planes, I think most of the time we are able to get away with it. And there is sometimes a FPM which is located over the disc, and sometimes it becomes fibrotic. If we can peel it off a little bit, it gives a better result. Otherwise, we may need to do a little disc drag. I try to leave all my cases under air, and in 27 gauge, I usually don't apply sutures. So this is the outcome of this case post-operatively. The next case is of a relatively more peripheral traction. In these cases can be managed with either a scleral buckle or doing a lens sparing vitrectomy. The sclerotomy ports may have to be modified with the shifting of the infusion cannula, either only the infusion cannula, either nasally, or which has been described by Professor Dogra and SIMAR, that we shift all the 3 ports nasally with the infusion cannula placed in the center and the cutter and endolite on either side. The intraoperative OCT which we have just helped me to delineate the vitreous membrane that was there within the folds. I do use triamcinolone because it helps to identify this small amount of vitreous separation which may be present in such cases. We don't need to induce the posterior vitreous detection PVD completely, but at least in the posterior pole, if we can do it, it does help to give a better result in terms of the anatomical success. So I'm using a forceps and just going up to the ridge, because beyond that it's very difficult to peel off these membranes. So just going as comfortably as up to the ridge and trying not to induce any retinal break here. And again, air exchange, and this is the outcome. The macula is attached and the fold has opened up. One more case. This is another case of a 4B detachment. Just speed it up a bit. This is somewhat similar to what Dr. Tapas has said. This is vascularly active disease. In this situation, we need to give a preoperative anti-VEGF at least 2 to 3 days before, and give it only when the child is fit for surgery. You can't just give it and then wait for clearance. Clearance has to be done before. Possible to as much of laser beforehand, and sometimes if it is not possible, we may need to augment it intraoperatively. So do that intraoperatively to reduce the vascularity. Here we just need to clear up vitreous to anterior, vitreous to the periphery and the inner arcade. Yes, this is the outcome after surgery. And I think in the interest of time, I'll just skip this. Thank you for patient hearing.
Thank you so much, ma'am, for some very interesting cases and showing the complete spectrum that we see of stage 4B. Now I'd like to invite Dr. Praveen Sen, ma'am. Ma'am has been a consultant, is currently a consultant at Agarwal Eye Hospital, Chandigarh, and ma'am has been a prominent retinal surgeon at Shankara Netralaya for almost more than 20 years now. So ma'am will be talking about a case of stage 5 ROP, the most extreme and the challenging of the cases.
I'll hold it.
Meanwhile, while ma'am is setting up, if I can ask Dr. Tapas.
Proper pre-op treatment to reduce vascularity. The second, on table
You use the
addressing
pendrive.
the
Pendrive
prolifs, yeah, not to disturb
Put it
and
on this only, no? Pendrive.
let the proliferation split, or in case the bleed do a diathermy, carefully, judicious diathermy. The third thing is that if there are not much proliferations which I have trimmed, and it's a flat retina, not much prolif, just blood is there, I wait for say 2 weeks to 1 month. They usually resolve. But if I know that there are lots of prolif which I have trimmed, and there is a large blood clot bridging between the prolifs, so those cases usually the clot tend to contract and the traction get aggravated. In those cases, I go earlier and do a vitreous lavage at cut it. So when I do depends on the size of the clot, the extent of the detachment, how the child is doing postoperatively.
If on ultrasound you always see a retina attached when you are doing that and you don't see much prolif, how long would you wait? What is your threshold for?
Yeah, maybe a
telling them-
month, maybe a month,
1
not more than that, because if it is too much, it can affect it can cause amblyopia. So I go there.
Thank you so much, sir. I think we'll go on to Praveen ma'am's talk now on stage 5 ROP.
Yeah, so I'll share with you the case of stage 5 ROP. So this is basically a case of premature twins. So they had a history of prematurity, born at 32 weeks, birth weight 1.2 kg and 1.1 kg, and they both presented with bilateral stage 5 ROP. So I did the surgery, and as we are familiar, the steps of surgery. I usually use an AC maintainer, then start the dissection after doing lensectomy. So just to keep it brief, what I'm trying to show is that as you do the dissection in this one twin, you can see I can easily remove all the fibrous tissue. I could go in, even clean up the funnel up to the disc. Peripheral cleaning was done, and you can see this is an open funnel configuration inside. It's okay. But if you see the second child, so this is how that first child had a very well attached retina and was fixating and following, and then slowly started recognizing toys and had some mobile vision. But if you see the second twin, so here again after lensectomy, I am cutting off the retrolental tissue, cutting the membranes, but you see the retina is just there. It's lying like a mass right behind the retrolental tissue. There are no planes, there is no funnel, there is no fold, there is no disc to see, and there is no peripheral trough. So this is the closed funnel configuration. So sometimes unless you go in, you do not know, and this child didn't do well. And basically why this happens is that the moment we know these are the principles, moment you have a break, this whole thing closes up, and this gives you a closed funnel configuration. So this is why the results of stage 5 ROP are also poor, and we need to give them a chance, and then only we will know which one will do well, which one won't. But sometimes things like corneal opacity, ectropion UV, posterior synecdoche, these can tell us that maybe there is an underlying break, and now they have been classified into stage 5B, and the results can be very dismal.
Thank you. Thank you so much, ma'am. Wonderful cases. So if I could just ask you, ma'am, now with the newer classification that we have of 5A, B, C, how often would you consider operating stage 5C?
So we even before the classification, and probably that is why the classification changed, because we all had publications and we knew that patients with corneal opacity, ectropia UV, they don't do too well. So you where if you will give a anatomical outcome of 5 to 10%, these cases the anatomical outcome is so much lesser. You could try, and I think ma'am has also tried two stage, that you try to first clear the synecdoche and hope the cornea clears a little more and then do more. But then the results are very, very disappointing in those cases. Vis-a-vis these, the idea is not whether you will try surgery in those or not. My idea of bringing these cases is the take home should be that when these things are not present, you must try for surgery. In those cases, the outcome will not be 5%, it may be 30% actually. Even almost one third of these cases, you'll be able to reattach it.
And as far as the incisions for stage 5 go, ma'am, do you prefer limbal, iris root? How do you prefer?
Once I know it is stage 5 and I'm sacrificing the lens, then I go limbal.
Always go limbal. Right. Thank you, ma'am. Any questions from the audience? Any pointers from Subhadra, ma'am?
So I was little curious that how they came up with the 5C, because the 5C in iCrop 3 it was not there before. Okay, now they just said those eyes with anterior segment involvement, and they've left it at that.
Yes.
Now my problem is, what do you mean by anterior segment involvement? Does it mean corneal scarring? Does it mean flat AC? Does it mean few posterior synecdoche? Does it mean a cataract? And do we have data to say that 5C, that is the anterior segment, is reflective of what is happening in the posterior segment? So I've been trying to collect my cases of 5C, operating them, and I can tell you that they are not always same. You can have posterior synecdoche and little bit of corneal lenticular adhesion, and yet the funnel may be quite easily opened like you did in the first case. And vice versa also, it may look like anterior segment is very normal. When you go inside, you see there's a lot of cholesterol, there's a lot of blood, and it's not as good. So I'm not really sure, first of all, what is the definition of 5C?
So I think it's only probability. So
No, I'm just saying.
Yeah.
So I think all of us, those who are doing surgeries, we should put 5A, 5B, 5C, what is there, but then put the descriptions also prospectively. And over 1 or 2 years, we will have enough data to say what is the relationship of anterior segment findings to the posterior segment findings. The reason for this is because we have shown by our basic science studies, which has already been published, that there is a subgroup of patients of ROP who have severe inflammation. They are inflammatory cells. And all this vitreous haze we talk about, we actually showed that these are actually microglia, and they are actually, MMP9, and there's an upregulation of the inflammatory component. Now, inflammatory component in vasculopathies, we have talked in CRVOs and in other PCVs, but we are not talking of the inflammatory component in ROP. So actually they have an inflammatory component. So whether that inflammatory component directly relates to the pathology in the retina is not clear. So I'm just saying that all of us, please note down the anterior segment findings, note down your intraoperative posterior segment findings, and we'll come up with the answer, and we can tell the world how much of concordance is there and how much of discordance is there. Then we can say that, okay, this is the probability.
Yes, we had published almost 200 cases of stage 5, and this was a subset. That time 5C was not a classification, but we separately analyzed cases who had any interior segment findings like posterior synecdoche, mild corneal opacity, or flat AC, and they definitely did poorer as compared to those which didn't have. So it cannot be 1-to-1 ratio, but then the probability of the odds ratio of their doing well is much lesser as compared to
That will be
the
there,
other.
but
Yes.
how much? I think that is what is important.
And the second, from the inflammation point of view, I think the formation of a retinal break triggers it. That triggers the
So now
inflammation. So that could also be a
the
possibility.
REG-RD component in setting of acute ROP stages has not been described. Again, we are recognizing these cases now. But mostly in ROP, when you talk of REG-RD, they talk of late onset REG-RDs, like at 10 years, 12 years, adolescence. But nobody is saying that acute phase, stage 4A, 4B, 5, can also have a REG-RD component. They talk of tractional and exudative. So again, I think documenting those cases and saying that there is a reg component, that is the ones that I am doing the imbrication technique or alternate techniques or not do a vitrectomy. So they will worsen. And if you don't recognize it pre-operatively that there is a reg component, it's actually convex, it's not a concave which you expect, then you will make mistakes.
Thank
So
you,
let
ma'am.
us, describe these cases more in our files, then we can analyze the data prospectively.
Thank you so much, ma'am. So I think what we learned for ROP is basically it's a relatively easier surgery dissecting the tractional planes wherever you see them and not being too aggressive about it, and then letting the retina and the nature do its own course so that it goes back and gives these children some useful vision. I will invite Dr. Diksha ma'am. So we'll move on to the spectrum of FEVR now, which again covers a lot of these genetic disorders which present with kind of retinal tractional detachments and complications. So ma'am will be presenting a case of FEVR with a tractional retinal detachment.
Thank you, SIMAR, again. So this is a case of a 15-year-old female child who presented with decreased vision of both eyes, left more than right, for 4 months duration, and it was progressive and gradual in onset. She had been using glasses for the last 7 years. There was no forthcoming significant family history, and she had been treated with laser photocoagulation elsewhere. So this was the findings at presentation. We can see in the right eye there is disc drag, there are supranumerary vessels, there is exudation at the macula, there is an epiretinal fold, there are some laser scars, and there is a peripheral tractional retinal detachment, but it's not involving the macula, so it is stage 3B FEVR. And I think this is quite a straightforward case of FEVR because of the typical clinical findings that are there. And the left eye, we see that there is again a drag of the macula towards the inferior arcade. There is a thick epiretinal membrane, there is an exudation, there is a tractional retinal detachment, and the fluid is tracking up to the macula. And after examining this child, we did ask again, we examined the parents, and then we came out with the findings in the parents. So she was 624 in the right eye and 636 in the left eye, and I've shown you where all the tractional components were there with the arrowhead. This is an angiogram which shows peripheral leakage, neovascularization, supraneural vessels, fluid under the macula. This is the examination of the father. Father had a history of retinal detachment surgery and findings which are consistent with FEVRs. So we planned vitrectomy with an added encerclage as well as a 277 tire in the temporal quadrant, along with the peeling of the epiretinal membranes. The use of peripheral scleral buckle, I think, really helps in these peripheral tractional detachments. Ma'am has also, Dr. Subhadra ma'am has also highlighted the use of imbrication technique. So this is a 25 gauge vitrectomy. So here we are doing the core vitrectomy. In these cases, sometimes again the PVD induction may be very difficult, and you may require the use of forceps. We should not tug and pull so much in these cases, and try to use gentle maneuvers, and forceps I'm using here. And then when I realized that it is really quite adherent to the underlying retina, and I might induce a retinal break while peeling at it, so I used a bimanual technique and tried to delaminate this epiretinal membrane from the retina and then be able to peel it. I completed the peripheral vitrectomy with the scleral depression. I also did the ILM peeling because the thick membrane that was there, it was pulling the macula. I thought maybe the outcome of the attachment and the configuration would be better if I do an ILM peeling. After doing the fluid air exchange, there was a lot of fluid. As you can see, it almost became bullous, and I was thinking whether to relieve or just leave it there. Maybe it could have been left, but I did made a small nasal retinotomy where there was no traction and drained it. Maybe that helped in a faster resolution of the fluid, and then put in C3F8 and then close the case. The outcome of after surgery. So we can see that the reattachment of the macula, and there are no longer any membranes that are visible there, and she improved to 6/18 parts after refraction. Thank you. Ma'am, left eye, the surgery was done. Thank you.
Thank you. Thank you so much, ma'am. think I'll invite Parveen ma'am first for talking on a case of ROP and FEVR Roper, because I think Dr. Tapas and mine case are a little bit related and we'll have them together. So Roper is a relatively
So again, thanks Tapas for this very interesting IC. I wish there were more people to benefit from it. And the clinical presentation of this case, he had a history of prematurity. Birth weight was 1.5 kg, gestational age 33 weeks, seen at almost 1 year of age. Right eye had unsteady fixation, left eye had some fixation and following light. Right eye had extensive retinal folds and was found to be inoperable, and no surgical intervention was done. And for this child, the left eye peripheral TRD was there. Child underwent lens sparing vitrectomy with peripheral encirclage as well, and the laser to peripheral avascular retina. This was how the retina looked about a year later, but the child was having inconsistent follow-up. Then he came to us at 7 years of age with this. So now you can see there is progression of disease, there is extensive subretinal exudation, plaque formation, TRD has increased. And now suspecting our Roper, because we don't really see such kind of progression in ROP. We did the FFA, and you can see the typical FFA, the bulbous findings that you see in a patient of FEVR and not really ROP. We even did genetic testing for this child, and the genes tested were LRP5, NDP, TSPN, VKN, and Frizzle gene, but we did not find any of these genes which were there. So this was negative, but we know that as we stand today, only 50% of the genes have been seen, and you could still have FEVR without any known gene. So we still need to look for more. So the common features between FEVR and ROP we have, and we all are aware of it, and the only thing which we feel holds them apart is the history of prematurity in ROP and no history of prematurity in FEVR. But what makes a premature child immune from having an associated genetic defect and having FEVR also? So could we have suspected it before? I think now that we are wiser, that we know that this entity exists, the asymmetrical picture and the presence of that large subretinal plaque even in the first year of life should have given us this indication that we could probably have a progressive disease, and maybe if we had emphasized more that he needs to come for a follow-up, he may have. But that time we all were not very much aware of it, and the patient also was not very consistent with follow-up. So the best would be, whether you are dealing with ROP or you're dealing with FEVR, make sure that the patients don't lose the follow-up, and follow-up has to be emphasized. When you do FFA, these are some unique features with FEVR, so which can help us differentiate. But as long as we are not doing genetic testing and FFA for all our babies, ROP babies, the best prevention would be that all ROP babies should be followed up to see if there is any progression. So that is my carry home point, that long-term follow-up is very important.
Thank you so much, ma'am. Ma'am, if I could just ask, in the initial surgery, the disease that came back on FFA, that was posterior to the peripheral ablation, any that was done during the
Yes.
initial treatment?
So the subretinal exudation itself has increased. So I think when the first surgery was done, we were the surgeon had only ROP in mind, right? So when you have ROP in mind and you are doing surgery at nearly 1 year of age, and you've done a peripheral encirclage also, and you've done a LSV also, how aggressive would you be with the peripheral laser photocoagulation? You may not do that so much, no? Until unless you had in mind that this is FEVR and I have to treat each bit of avascular retina. So the difference now and then, this is 7, 8 years, 10 years ago. So all of us probably didn't even know that Roper is something like that is there. So now that we know, especially that is why that subretinal plaque, which has been there at time of presentation, that should have given us the clue, because I did search literature. Exudation can be seen in ROP, but it's more fine, more peripheral, more subtle. You don't have these kind of subretinal plaques. So that should have given us the indication it is something more than ROP.
Yes, ma'am. If I could just ask Subhadra ma'am, so we see a lot of these babies with, ma'am, features like FEVR, but we don't get a family history and neither get the genetics positive. So are we missing something here? Are there any autosomal recessive genes that are being involved? So what should we be labeling them FEVR if neither of the parents have the disease on FFA also?
Yeah,
And
so
we don't
I
get them.
have very bad experience where I had twins, both had detachment stage 5, but they were sort of borderline preterm. And if you see the case sheet I have written there, somebody referred as ROP, then I wrote FEVR stage 5. Okay, so I wrote that they have actually FEVR, they were twins, just borderline preterms with like I think 1.8 kg. Then they came for follow-up, so they are a stage 5 blind. Then in the follow-up, I have crossed it and written ROP, and I've written stage 5. And then after 5 years, they had another child in the family who was born with leukocoria. So I made that mistake. But I think that more I try to think is this FEVR. Okay, and when we start thinking, as Praveen said, then we see the findings, and we can pick up these Roper cases. Okay, we can pick up that although this is preterm, but this is not ROP, because one thing not very clearly told in literature, the ROP ridge will always move. It will never be static. That is one clue. Second, FEVR almost never will happen only in zone 3, because it's a arrest of angiogenesis, and angiogenesis occurs in zone 1 and 2. So once it is arrested there. The vessels can change their character. They can remain static like those bulbs, or they can form new vessels, or they can exudate, or they can just remain silent for many years, but they will not move forward. Whereas in ROP, you will find evidence, even if you see them in stage 4A, 4B, you will find evidence that there was a ridge somewhere, there was some vitreous there, and now the ridge has changed its position. So that's how you can, if you look carefully, you can differentiate the two. Autosomal recessive FEVR is known, X-linked FEVR is known, autosomal dominant is also known. And so whenever we are in doubt, we definitely examine the parents and siblings as much as possible. And wherever possible, we do the genetic testing. But your clinical, alertness is important, and keep them under clinical alertness. And we see this, sometimes they will come back with something, and then you immediately go under GA and examine them in detail, and you can pick them at earlier age, and you can do something more.
Thank you, ma'am. Yeah.
For laser, and the child was some 16-17 days. Prematurity was not too much. So when these things don't fall in place, and then I saw there was no defined ridge. It was all posteriorly and scattered subretinal exudation with bulbous kind of dilatations which were seen. So that is FEVR. I did laser for FEVR for both eyes, and did everywhere, not just in the periphery or whatever. I did very much posterior. So now that we are aware, we need to pick it up very early. And if any associated systemic issues are there, look for them. If it is there, definitely FEVR.
Right. Thank you. Thank you.
Microcephaly and delayed walking.
Micrognathia, microcephaly, and
KIF11 gene, I think that.
LRP5 causes osteopenia.
Ost-
They will
osteo-
tell the child is not walking.
Can be taken up.
And we stopped at the edge, right?
Edge.
You didn't go right up.
No, I didn't, because I knew that I was applying the tire there. Yes.
Right. Thank you so much, ma'am. I think we'll move on to Dr.
SIMAR, thank you all. I would again share with you another interesting case of FEVR. You see this was a baby with prematurity, but the profile was not conducive of a retinopathy that requires laser. So somewhere this is the child was brought at a chronological age of 5.5 months, lasered elsewhere for FEVR at 1 month of age, and this was the diagnosis. This is the left eye, and left eye was doing well, regressing fibrovascular proliferation. Right eye had a, as we can see, the disc drag narrowing of the blood vessels and fibrovascular proliferation at the zone 1 and zone 2, and an RD which was progressing during the follow-up. There is a progressive RD this side and this side also, with few exudates there. Interestingly, why the mother looked familiar to me. So when I looked at it, I thought the baby was advised for surgery So laser was done at Bangalore, then they went to Delhi, but surgery they didn't do. They came to me again. So when I looked at it, I found out that a few months ago I saw her with a baby elder sibling who had both who was blind from the birth and had retinal fold both the eyes, and this was the profile of the baby and the picture. You can see that the retinal fold in both the eyes, and I suspected it as a case of FEVR, and but the parents were unremarkable with the fundus finding alone. They denied the fluorescein angiogram, and there was no consanguinity. I suggested, and interestingly, that time the mother was pregnant for 7 months. So I asked for a genetic testing of the child, and also counseling with the obstetrician for a probable possible early delivery, or at least fundus examination at birth. But she forgot that, didn't do that. She came, presented after 1 month, and after 1 month the laser was done outside, and this was the detachment. As we can see here, there was a retinal fold, the fibrovascular proliferation over the ridge, and the ridge was curling inside, indicating that there is a with the taut posterior highlight bridging between disc and this one, indicating that the ridge is going to override over the disc. And at the summit there was a vitreous condensation and anteroposterior traction, and so as surgery was done to address this 25 gauge vitrectomy. My primary aim was to address that anteroposterior traction. There was a from the summit we dissected that, and followed by the highlight which was bridging between the ridge and the optic disc, and followed by from the ridge to the lateral one. I am a little bit conservative when while dealing cases where the retina is mobile, so that's why I was not that aggressive in peeling the vitreous over a mobile retina. And mobile retina can break off, and your outcome can change like anything. So then also the tractional vector between the optic disc up to the vertical limb of the T, probably proliferation along the highlight, that also need to be carefully dissected out from these membranes. That's what we did, and I will just quickly go to the outcome. You can see that the detachment slowly, the prolif regressed, and detachment slowly regressing, and this is the final follow-up, and the exudate and the tractional detachment subsided with a myopic refraction. Thank you so much.
Thank you.
Yeah, yes, it was in June 1. So this picture is not showing. Laser has been done all around. RAJAN was well done. That was an advantage for me.
Thank you so much, sir. Last one, yeah.
I now invite Dr. SIMAR to give a talk. Present his case. He's a very passionate pediatric surgeon as well as a great person.
Thank you so much, ma'am, for the kind introduction. So I'll be presenting a case of Norris disease, then that again borders onto the FEVR spectrum. So this was a 7-month-old term child brought by parents for leukocoria noticed for the last 1 month. He was a full-term normal vaginal delivery, no NICU stay, no supplemental oxygen, and no in the perinatal period. So this was the presentation. You can see the right eye on the this side and the left eye. The left eye had the fibrotic membranes attaching right behind the lens, and we did not have much view. It was smaller in size also. And the right eye, we could see this kind of focally attaching at one place in the lens, and we could see some amount of retina over here that you can see over there. So our differential diagnosis at that point of time was congenital FEVR, Norris, or atypical ROP. So this was the examination under anesthesia for both the eyes. You can see the right and the left eye. Left eye almost like stage 5 ROP, very shallow AC, and synecdoche. And the right eye, you can see that the pupil was dilating. There was some synecdoche, but it was well dilating, and we could see that thing completely coming towards the lens. So we decided to go ahead with surgery for the right eye, and I'll quickly go through the surgery. Once we entered the eye, not very fibrotic, and maybe we are going in a little early also in them, and this was 7 months old. So this was very fibrotic, very taut, very difficult to dissect. And I'm not just pulling it, I'm using my cutter, but it took some time to dissect. Just trying to salvage the lens of the liver and keep that small fibers, small bit attached to the crystalline lens. Then we cleared out the vitreous hemorrhage, which was very dense interiorly. You can see the retina kind of a twisted kind of fold. Couldn't really see the disc or any vasculature in the case. But we still wanted to try and clear the media and give the child whatever best chance that he could have. Then again, this bleed was so tightly adherent to the underlying retina that the differentiation of planes was a little difficult even when coming from both the sides. You can see the gliotic retina that we could see, almost like the retina had not formed, which is sometimes described in Norris disease. So once we did this, we completed the laser all around and just finished the case with a fluid extension. So this was the fundus picture post-op, 6 weeks. You can see, we could see this retina falling back, some amount of exudation subretinal. This was the part that was left attached to the crystalline lens. And this was the posterior pole that the child had. He could fix and follow light, but we don't know what other visual potential the child might have. The genetics showed a pathogenic variant in the NDP gene, hemizygous. And when we evaluated the mother, you can see the supranumerary vessels coming out of the optic disc, very typical for FEVR. And the angiogram also showed a stage 2 FEVR in both the eyes, which was subsequently lasered. And the genetics proved the presence of heterozygous condition in the sibling also, which was 3 years old but doesn't show any signs of FEVR in that case. Thank you. Any questions or opinions, ma'am?
I just want to say, recently there was a baby in a normal hospital in Bangalore, and they are doing the red glow, and the report said red glow failed on day 1 of life. And then I said to the parents what happened. They said at one day, they said there's no glow, you come after 2 weeks, then senior will see you. Then senior has seen and written red glow fail, and then referred to the eye specialist in the city in Bangalore. Then in the eye specialist, they have taken a fundus picture. One eye is leukocoria, no view, other eye almost looking like this, like total vitreous hemorrhage, but I could see in that fundus picture little disc, and they have written no, this is Norris or FEVR and no treatment advised, and told that the eye is going to be blind. And then they reached me after 2 months. By that time, both eyes are sort of gone. So this fulminant type of FEVR, which occurs at birth, is not very well described in literature because they don't reach us on time to see this picture.
Yes.
But this is exactly what we want to do, that if you see, even if you see little stalk, even if you see retina is dysplastic, at least go in. Sometimes you may have to use Avastin also. Go in and do that vitrectomy. You may salvage little bit of formed retina, and at least you save the eye from going into the eyes, and some part of retina may attach, and that part may be functioning. Okay, so I think excellent surgery. We should attempt surgery in all these eyes as quickly as possible, and not make them go from one place to another.
Right. Thank you so much, ma'am. I invite Professor Raman sir now, my mentor, who will be.
That lot is not more than 6 patients in my whole career. So I'm so happy because I don't want to see any child with pain actually. So I've not operated more than 6 patients. So Dr. Jagatram has a very long series, but I've been doing this PHP. We work with him. So I was managing his posterior pole PPP. You can play it. Kar diya? Yeah. Oh, sorry.
You just play this.
आप प्ले कर दो वहाँ से. Yeah, I'll do it. Sorry.
can start the video again, please.
I'll do it. I'll do it. Are you okay now?
Yes, I'm fine, sir. Thank you.
So this was a patient had a white cataract and a eccentric kind of this thing. So after that, I put in an AC maintainer, and we Dr. Jagatram was planned to IOL for him. I pursued no IOL for him. So this is what then I took over, and then we just this is how we go. That once you have area is clear, we thankfully this patient didn't have much of a vascularization in the capsular area, or in the ciliary body was good. So all he had was a eccentric stalk, which was going deep down to the optic disc. And this is how these are the cartoons given by Michael Tracy group, that there's a cloak kind of thing. Retina is getting cloak, so from all the sides. This is how this if this is how the problem starts. So this PHPV, the persistent fetal vasculature is surrounded all side by the retina, and this is where the problem is, and this is where the retina surgeon has to come to play to salvage whatever they can. So this is one of my most aggressive surgery, where I did use this first Canacot to take care of all the hyaloid in this patient. And again, like in a usual vitrectomy, you have to do these process very meticulously. Kids hyaloid is not easy to remove. There is always some part of the retina which is between the attached and the cloaked retina, so that appears little lifted. So you have to take care that you don't create a RD there or a break there. So you have to create go very very slowly, and these surgeries are shown in 4 minutes. Might have taken me 2.5 or 3 hours there on sitting on this case under GA. This was a 4-year-old boy. And then I said most aggressive case, so I did ILM peeling also in this case. I think I may have gone to some VRSI and saw some Egyptians doing this surgery, so I did some ILM peeling in this patient. I did, because I thought that it will ensure that I have taken care of the hyaloid. So you can see that ILM has been peeled all around, and this was done temporally also, and nasally also. And again, it has to be done under utmost care, because we are not planning to do any iatrogenic harm in these patients, because causing a break in these eyes would lead to a tamponade or this thing. And this was done. You can see how the fetal vasculature is cloaked from the retina from all sides. This fold was there all the time, and all we have to do is just to take out this fibrous tissue and bring it to the top, and then you can cut it. This is what is being done with the I have shifted to the bimanual surgery also. I'm using chandelier also in this patient. So yeah, sorry. So once all the fibrous tissue reaches to the top, then it's the time to cut trim the stalk to the max, so that here you have to take care you don't cut the retina there again, because there is sometimes some bleed is there, which is taken care by just increasing the pressure of the eye. And this again, it is being done bimanually. You can see the forceps and a scissor in my hand. And this is followed by again, because I have not caused any iatrogenic injury, and just do a fluid exchange and leave these eyes. And these are again very very 3/60 or 4/60 vision, and they need squint surgeries, but these are precious eyes. Sometimes you have to operate them. You always give them a chance in these eyes actually. Thank you.
Thank you so much, sir. Very meticulous surgery. In the interest of time, I would
Yeah.
move on to the last talk of the session by my good friend Dr. Mohit. Sir is an assistant professor in the eye department at Advanced Eye Center, PGI Chandigarh, and sir would be talking on Coats disease with epiretinal membrane, one of the spectrum that we haven't covered in the pediatric vascular diseases.
Thanks, Simar.
This is my last case. Actually, I've gone aggressive. I have not seen any change in the results, so I will not recommend ILM peeling in these patients. Just do trim the this thing the stalk till the edge and remove the hyaloid
And
deposit.
lens management, sir, would you recommend combining it with the cataract surgery or doing a
And
lensectomy or
if eye has a potential, if the macula is no stretched up, is not less, it all depends how much is the macular, the foveal stretch is there.
yes,
So if the stretch is not enough, is not great, so you can put an IOL there. But these things can be done later on also. You can always put them, give them contact lens or plan TSFR later in the life.
yes,
You know.
right? Thank you, Subhadra ma'am. If you have any experience with
We call the pediatric cataract surgeon, and if the corneal diameter is more than 10.5 and the capsule rim is good, they put the IOL same time. But if the corneal diameter is smaller, then they don't put. Then they don't wear contact lens as much. They have a esotropic eye, so really you don't have too much of good outcomes with that. So if the corneal diameter is good and capsule
I
rim
think
is
both
there.
this and as well as course diseases are a problem, ma'am, because they're mostly unilateral and
Yeah. But I
it's a
haven't done so much dissection. Most of my PHPV cases, if the stock is there, I just cut it
just
and
dissect it
let
and
it fall.
let it
Anyway,
fall
you
back.
can't open that retina, and it's a dysplastic retina. But important thing is to identify where the stock ends and the retina starts, and cut at the stock, not at the retina. So it could be right at the disc, it could be up, it could be up. So that's it.
Right. Working.
Saw nearly about 91 cases that we analyzed. So it is the interior and posterior presentation. So the interior presentation would largely be just this stalk. So all you need to do is, as ma'am said, if you have a pediatric cataract surgeon who could do it, and you just cauterize the stalk and trim it and leave it. But some of the posterior ones are really bad, which has microphthalmia, which have the interior proliferation, which I think Dr. Sengul Losdick has recently come up with a paper with the anterior elongation of ciliary processes and tenting, and they behave like almost like a stage 5 disease. And then you have to go through limbus, remove the lens, and see if you can salvage any useful vision. So the spectrum of the disease is quite varied.
Right.
You have capsular vascular